This is the second part of the presentation on diabetes, and this segment will focus primarily on complications of diabetes. So the three major complications that we'll talk about will be hyperglycemic, hyperosmolar, nonketotic coma, diabetic ketoacidosis, and hyperglycemia, although we will have something to say about hypoglycemia at the end of towards the end of the presentation. Hyperglycemic, hyperosmolar, nonketotic coma occurs primarily in conjunction with trauma or infection in patients over age 60 with type 2 diabetes. The characteristics are listed on this slide. The problem develops over weeks with a persistent diuresis due to glycosuria. The diuresis not only results in a massive total body water deficit, but also a solute diuresis. The patient presents with the classic findings of polyuria, polydipsia, and hypovolemia leading to hypotension and tachycardia, with consequent end organ hypoperfusion. The mental obtundation or coma may occur due to hyperosmolarity without necessarily being due to hypoperfusion. Vascular occlusion may occur due to low flow states. The treatment consists primarily of massive volume resuscitation, sometimes as much as 1,500 milliliters per hour, and insulin. If the serum osmolarity is greater than 320, hypotonic saline is usually recommended. When the serum osmolarity is down to 320, isotonic saline replaces the hypotonic saline. Interestingly, the mortality rates of hyperglycemic, hyperosmolar, nonketotic coma are 10 to 15%. With regard to ketoacidosis, it should be evident that delaying surgery to eliminate the ketoacidosis is counterproductive if the surgical condition is creating the problem. Nonetheless, some degree of volume expansion and treatment of hypokalemia is associated with a decreased incidence of intraoperative hypotension and arrhythmias. The volume deficit in this patient population is generally somewhere in the vicinity of 3 to 5 liters, but may be as high as 10 liters. In terms of treating the hyperglycemia, in most circumstances, the patient will end up receiving a bolus of insulin followed by a continuous infusion. During the first 2 hours with volume resuscitation, the glucose levels may fall precipitously, but in general, the maximum rate of decrease in serum glucose is about 75 to 100 milligrams per deciliter each hour. This occurs because there are a limited number of insulin binding sites. Once the serum glucose declines to 250 milligrams per deciliter, most people would advocate that glucose should be added to the IV fluids. Volume expansion needs to be moderately aggressive. Most people recommend replacing 1/3 of the deficit in the first 6 to 8 hours and the balance over the following 24 hours. But remember, patients with diabetes probably do not have normal ventricular function, and patients with a history of significant myocardial dysfunction may benefit from some form of monitoring of LV volume during treatment of ketoacidosis. Blood gases will reveal an increased anion gap acidosis. Don't get me started on anion gap acidosis. It drives me absolutely crazy. As far as I'm concerned, it's almost as evil as pH, where the hydrogen ion concentration increases as the pH decreases and where the relationship is nonlinear. The reason I'm so incensed about anion gaps are twofold. Number one, there are 2 different formulas for calculating the anion gap. So a value that's normal in one formula will be abnormal in the other formula. The second thing is, by saying there's an anion gap, it implies that the gap should be 0, when in fact, even under normal circumstances, there is an anion gap present. But again, I won't discuss that any further because it drives me absolutely nuts. Anyway, contributors to the anion gap acidosis may include ketones from the ketoacidosis, lactate from hypoperfusion secondary to hypovolemia, or organic acids from renal insufficiency. The treatment of the acidosis with sodium bicarbonate is controversial. On the one hand, increasing the pH to greater than 7 clearly improves myocardial function. On the other hand, rapid correction of the acidosis may cause CNS problems due to a paradoxical worsening of CSF and CNS acidosis as bicarbonate is increased to carbon dioxide and diffuses across the blood-brain barrier, and a decrease in cerebral blood flow. Although losses of water exceed losses of sodium, serum sodium levels are usually normal. A factitious hyponatremia may be present, caused by the elevation of serum glucose or triglycerides. Potassium deficits are commonly in excess of 3 milliequivalents per kilogram and may be as high as 10 milliequivalents per kilogram. Think about that. In a 70-kilo person, you're talking 210 to 700 milliequivalents of potassium. You obviously can't administer that as rapid bolus, but you do have to monitor serum potassium levels because as you give insulin, the potassium moves into the cells. Remember, glucose and insulin are one of the treatments for hyperkalemia. That potassium, which goes intracellularly, is not lost from the body. In addition, however, as intravascular volume is expanded, more sodium is delivered to the distal tubules of the kidney, resulting in additional potassium loss. Obviously, that potassium is lost from the body. Phosphorus is another potential problem. Hypophosphatemia occurs because of tissue catabolism, impaired cellular uptake, and increased urinary losses. Hypophosphatemia may cause muscle weakness, leading to respiratory failure due to diaphragmatic dysfunction and decreased cardiac output due to decreased myocardial contractility. It can also cause dysrhythmias, altered mental status, and seizures. Most of these complications occur more commonly with chronic hypophosphatemia, such as with chronic alcohol abuse. In general, there's not a significant problem with hypophosphatemia in ketoacidosis, but it can occur. Replacement of the phosphorus is generally recommended if the plasma phosphate is less than 1 milligram per deciliter. The mortality rate for ketoacidosis is generally 5 to 10%, but it's substantially higher if the patient is over 65 years of age. This table presents the values for the primary disturbances in diabetic ketoacidosis compared to hyperosmolar coma. It's probably worth looking at because this could be the basis of a question on the in-training exam or on the board exam. Hyperglycemia is another problem. Before the year 2000, there was generally an approach of what people might now term permissive hyperglycemia. A glucose of 250 or less generally wasn't addressed. With this approach, observational studies documented that up to 80% of cardiac surgical patients developed hyperglycemia. In 2001, there was a landmark article by Vandenberg published in the New England Journal of Medicine. That study reported a decrease in mortality in ICU patients if the serum glucose was maintained between 80 and 110 milligrams per deciliter, as compared with the patients who were allowed to have a serum glucose between 180 and 200. Despite several people pointing out limitations of the study, for example, it's not possible in clinical care to duplicate the intensity with which these patients in the study were monitored, several government agencies and the American Diabetes Association adopted the recommendations advanced by Vandenberg and used them as an indicator of quality. In the first few years after the Vandenberg study was published, a series of studies were done which failed to document any difference in mortality, whether the patient was allowed to have a blood glucose of 140 to 200 or controlled at 80 to 110. But it did demonstrate that as many as 28% of patients managed according to the tight glycemic guidelines developed significant hypoglycemia. In 2009, a study involving over 6,000 patients in over 40 centers was published. The study used an algorithm known as NICE sugar, which stands for Normal Glycemia in Intensive Care Evaluation Survival Using Glucose Algorithm Regulation. That study documented that not only did adherence to the target of tight glycemic control result in an increased incidence of hypoglycemia, but also documented an absolute increase in mortality in these patients. Subsequent meta-analyses have reported no overall effect on mortality for patients managed along the tight glycemic control guidelines, but an absolute increase in the frequency of hypoglycemia. The American Association of Clinical Endocrinologists and the American Diabetes Association have subsequently revised their recommendations and currently recommend that insulin infusion not be initiated unless the blood sugar is greater than 180, and that once insulin infusion is started, the target should be 140 to 180. In addition to these complications, there are also vascular complications. Microvascular complications refers to microcirculatory disease with impaired autoregulation and vascular tone. Because hyperglycemia is critical to the development of microvascular disease, tight glycemic control delays the onset and slows the progression of these effects. Nephropathy occurs in 30 to 40% of patients with type 1 diabetes and 5 to 10% of patients with type 2 diabetes. Treatment of hypertension can slow the progression of the disease, and ACE inhibitors are specifically beneficial because they slow the progression of oliguria and the decrease in glomerular filtration rate. Peripheral neuropathy is another problem not infrequently seen in the pain clinic. Sensory deficits are more common than motor. They generally begin in the toes and progress centrally. This distribution is commonly referred to as stocking glove distribution. Treatment involves glucose control, primarily, and treatment of pain with non-steroidal anti-inflammatory agents, antidepressants, and anticonvulsants. With regard to retinopathy, visual impairment can range from minor changes in color perception to total blindness. Tight control of blood glucose and blood pressure can decrease the risk of development and slow the progression of the disease once it's started. Perhaps the thing that merits the most consideration in this area is autonomic neuropathy. Symptomatic autonomic neuropathy occurs in only about 5% of patients with diabetes. Resting tachycardia and loss of heart rate variability Resting tachycardia and loss of heart rate variability during deep breathing are some of the earliest signs. Failure of the heart rate to respond to exercise is indicative of significant cardiac denervation and is probably associated with decreased exercise tolerance. Orthostatic changes in blood pressure and heart rate are other indicators of cardiovascular autonomic neuropathy. It's in this patient population, presumably, that dysrhythmias are believed to be responsible for sudden death. Impaired gastric secretion, impaired gastric motility result in gastroparesis, which is present in 25% of patients with diabetes. If symptomatic, patients will present with nausea, vomiting, early satiety, bloating, and epigastric pain. With regard to macrovascular complications, patients with diabetes account for 25 to 30% of patients presenting with myocardial infarction. Aspirin and statin therapy should be considered for all patients with diabetes. That ends the section on diabetes complications. The third section will address anesthetic management of patients with diabetes. Thank you.